Top Bed Talk.
Hello, my name is Jason and I'm the nurse lead for POPs at Guy's and St Thomas's Hospitals. Over the next 10 minutes or so, I will be discussing workforce and how we need to be creative in ensuring we meet the needs of our patients and what is an expanding perioperative pathway. First, it's worth asking, what is perioperative care? This may seem a daft question, but then I suppose I am preaching to the converted. But outside of our enthusiastic collective, what does perioperative care mean? The reason I ask is that in my experience, there's still ambiguity in its meaning. Within nursing predominantly, perioperative medicine is still very much focused on the on-table episode. I see this being part of the RCM Periop steering group, which is made up of mostly theatre practitioners and anaesthetic room staff. Very few staff from outside this arena. What we know from the relatively recent work by the Royal College of Anaesthetists, that perioperative medicine has evolved into an all-encompassing pathway of care, quite rightly putting the patient at the centre of the care they receive, with treatment tailored to their individual needs. But when you factor in the sheer number of patients that have surgery every year, trying to design a one-size-fits-all service isn't manageable. So when we think about workforce planning, we need to think about how we target and utilise differing skill sets at those patients who present the biggest challenge. And this is the high-risk group. This group is often of an older age and will present with multiple issues or hidden disease that isn't easily teased out in our standard pathways of care. And it's no surprise that older people have worse outcomes in comparison to their younger counterparts. Multiple reports detail this. Not only is this true across clinician-reported outcomes, such as morbidity and mortality, where 4 out of 5 post-operative deaths are in this high-risk group, it's also the same in patient-reported outcomes, particularly in terms of functional or cognitive recovery. And finally, we see poorer performance in process outcomes, such as length of stay, with an increased cost in relation to direct care in hospital or social care. And there's lots to consider when we look at the reasons why this group does worse. While it's probably a combination of many factors, it's often the complexity of the patient being exacerbated by the complexity of the pathway itself. And added to this, we still don't really know how best to manage these complex patients. We have evidence to support intervention in single organ pathology, but less so when it comes to how to put this evidence into the arena for the multimorbid patient. We know that surgical patients are predominantly managed by surgical and anaesthetic teams with ad hoc support from on-call medical and therapy services. But there is little training specifically for the same surgical and anaesthetic teams in how best to look after this patient group. As a result, care becomes reactive and lacks coordination. And this presents a wicked problem. And it's only natural that when looking at how we address some of these issues, we look at who is best placed to deliver the care needed to start to improve on those poor outcomes. While we recognise the high-risk patient perioperative pathway requires multidisciplinary team working, nationally there is a variety in how this is delivered. All recognise the need for an enhanced assessment process, and primarily these services are provided by our anaesthetic or care of the elderly colleagues, utilising different advanced assessments and risk stratification. Drilling this information down further, where we see the most progress in how to support the high-risk patient is the integration of elderly care medicine into the surgical pathway. The higher prevalence in this evidence is partly as it was highlighted to the elderly medicine community first, with reports from the early 2010s detailing the inconsistencies in care for the older surgical population. Despite other surgical geriatric liaison services existing, such as orthogeriatrics, it's these reports that led many services to gain traction with the recognition that the comprehensive assessment process and the core skills seen in this specialty were possibly transferable to the surgical setting. This model of assessment was felt to be common sense. As we know, research study has supported this type of input in not only improving the primary outcomes from surgery, but also impacting the patient and process reported ones also. So, bringing it back to extended roles and workforce, given that much of the established surgical liaison services are in elderly medicine, it's not surprising that much of the development in extending teams and care delivery has happened in these services. But, as we know, we have struggled. We know there is a gap in the workforce and a gap in training. For one, there aren't enough geriatricians, and expecting our enthusiastic anaesthetists to provide overarching pathway support is unrealistic. But we also know that throwing more staff at the problem isn't an option. Just having more staff doesn't always equate to better care, especially when the staff do not have the skills required. We've seen this repeatedly. Often it's a nurse or junior doctor added to a team to provide care, only to fail in the task as they are either not prepared or their roles are nebulous and ill-defined. These positions often fail, losing funding and momentum quickly, and what is more frustrating is that we don't learn from these mistakes. The pattern repeats. So what do we need? Well, luckily, when looking at workforce design, we already have the major players in place: the consultant surgeon, the consultant anaesthetist, the physician, all providing expert support. What is lacking, and often undervalued, is the individual or individuals who hold the pathway together. And if we think about what this person or persons has to be able to do, it boils down to three things. It needs to be someone with whole pathway expertise, someone who's present and able to access all the different components of the pathway. They should have knowledge and skills in comprehensive assessment, allowing them to be able to provide timely initial assessment, care planning, and appropriate follow-through on treatments, whether this be preoperative optimization or post-surgical complication management. And lastly, they need case management skills, the ability to independently take ownership or liaise within any aspect of the pathway, acting as the bridge between the component parts, being the first point of call for the patient and a conduit for information between them and the MDT, and vice versa. But this is easier said than done. Who can we expect to do this? Well, it's not easy, especially given we've just spent billions on a COVID pandemic and continue to spend billions. We will all need to be creative if we're going to fashion an effective workforce where funding for new services is limited. What I will do now is talk a little bit about how mine and other services around the country have looked to address this problem and what personnel are out there when looking to supplement your perioperative teams. These will include allied health professionals, physicians associates, and nurses. So let's start with allied health professionals, our experienced OT and physio colleagues. We already see these disciplines leading on liaison type services nationally. We have physiotherapists and nurses working together to deliver our older person liaison service at Guy's and St Thomas's, coordinating inpatient transfers of care and linking with community services. And there is evidence in the literature in the benefits of this type of input with quality of life improvements and reducing hospital admissions. And then what about pharmacists? Well, we do see some but limited evidence in the pharmacy group with improved drug knowledge and compliance. And whilst the evidence suggests no effect on reducing hospital mortality, talking to colleagues, we think this underplays the impact of having a pharmacist within the MDT, as they likely do impact on reduction of drug-related harm. Then probably the most popular and current favourite is the physician's associate. Initially developed in the USA, these are now being introduced in a number of surgical and medical teams in the UK with some success. They are mainly charged with basic assessment and management of patients, but usually under physician supervision or in pathway-driven care, so may be ideal for the perioperative pathway. Access is via a 2-year post-grad programme, with an increasing number of colleges providing these, 37 at the current count. What is worth saying from the outset is that they are dependent practitioners, and at starting, they have a narrow specialty focus. Many require further training to order tests or prescribe medicines, and there is limited evidence of benefit in patient care. Though a recent NIHR study noted that physicians' associates provided stability within medical teams and work assessments comparable to junior doctors when working in accident and emergency. So this sounds like a viable option, with transferable skills into the perioperative pathway, though it does come with limitations. And then finally, unsurprisingly, we come to my favourite group. But we know the addition of a nurse into the perioperative team is usually the first option many consider. And I personally think it's the most effective and practical way of enhancing your team or service. Here we have a profession that has a strong foundation in holistic assessment and care planning. They also benefit from having a semi-structured career framework to access advanced practice. I say semi-structured as this has been a long time coming, with work by Health Education England and the Royal Colleges of Surgeons and Physicians soon to produce clear competency frameworks of what defines and should be expected in advanced practice. And while we don't see any direct evidence of benefit in the perioperative pathway, we do see evidence in single organ management, transfer of care, and mortality reduction. So what does this look like in practice? Well, utilising nurses is the direction POPs has taken when expanding our team. This is because we've also struggled to fill our consultant posts, but we also recognise that the skills a nurse brings to the role complement the service and the team as a whole. And if we look at the POPs model, here we see the nurses in our team having input at all stages of the pathway. And this works for us. Our experience has highlighted that every nurse has varied skills, all bringing something different, with none of my team coming from anaesthetic or elderly care backgrounds. Each nurse is paired with a consultant as surgical specialty, and from the outset, each is expected to develop skills to be an independent practitioner. This starts with an initial focus on comprehensive assessment. And here we have a typical timetable. This is from our CNS, who provides in-reach into the GI unit at St Thomas's Hospital. To supplement the on-ward work, each nurse is attached to a POPs, comprehensive geriatric preoperative assessment clinic. This is usually once a week with timetabled admin for the follow-up of results and case management. As you can see, most of their clinical work is patient-facing, with often an early start in the surgical wards. This allows for early detection of patient issues, but also, and I think just as important, it helps build relationships in the teams you have to work with. And this works because it is underpinned by the senior medical team with shared responsibility. On a career progression level, the posts are supported by both a consultant and a senior nurse manager, with joint appraisals and multidisciplinary feedback. And this is reflected in the job description. The team encourages autonomous working, but this only works because there is a robust support network through formal and informal MDM discussion with easy contact to the senior team to support and aid shared decision-making and care planning. And this is all well and good. Brilliant work, I'm sure. We're an established service, well known at GSTT. Our roles have evolved with the service over time, many years in fact. But how does that help me, I hear you ask? How do I practitioner? And when we've done these conferences previously, we're always asked three recurring questions. What skills do you need to have? How can you upskill new staff? And then how do you keep hold of them? With this especially pertinent in a time when money is tight and services want quick results. If we briefly discuss the first question, let's be honest, you are highly unlikely to find an off-the-peg specialist practitioner to step into your team straight away. You'll have to grow your own. But see this as a positive. No two perioperative services are the same, some are similar, but most differ. The homegrown option is often cheaper and allows you the scope to mould to your own service needs. Long story short, there is no magic background or skill set you should be looking for. As mentioned, none of my team worked in elderly care or anaesthetics. Most were ward nurses, one worked in outpatients. While some experience as a jobbing nurse or practitioner is probably desirable, the only other real must is wanting to do it. Beyond that, everything else is a bonus. So when looking for your new team member, don't initially focus on skills, focus on the person. Spend some time asking around on the wards or departments you work in. See if there's someone wanting a challenge and keen to give it a go. But once you have your person in post, you'll need to quickly factor in support and development of the practitioner. To start, I speak from experience as the one leading the hand-holding. It starts with a lot of shadowing and one-to-one support to build the confidence in the assessment and communication skills needed. This is then further enhanced by college courses, such as the Advanced Assessment Skills course, and prescribing. These can be undertaken over time and are often something that are taken at later stages as the staff member gains confidence as an autonomous practitioner. And you can see how this fits into our local training programme. we have found this initial close one-to-one and MDM support invaluable in developing those early bespoke learning plans for the individual, who is also supported by our in-house educational timetable. To ensure the practitioner isn't struggling, progress is overseen and monitored at a 6 and 12 monthly appraisal. When looking to share our experience and knowledge, POPs also has a national education program. This is like speaking at these conferences or even our own, feeding into educational programs such as the UCL Masters, and soon to be up and running POPs educational module for allied health professionals, nurses and physicians associates. The last of these is something I'll briefly discuss now. This is a wider piece of joint work undertaken by myself, the BGS and King's College Hospital, and has been driven by the many site visits, questions and calls for help when developing a wider team. Drawn from our experience, we've designed a capability framework for the developing Periop practitioner. This details levels of capability from band 6 to 8, with clear expectations of clinical responsibility. The focus throughout is direct patient care. The framework forms a template of learning that supports the educational module, which I'll discuss next, or can just be used to develop a bespoke learning plan at your centre. Our educational module then comes in two parts. The core module is a taught programme of learning with the aim to provide this via a virtual classroom. You will need to be present, but via an online meeting platform. Alongside the taught component, there is the completion of a BGS-hosted perioperative care module. This is online and is free to BGS members, so please sign up, but there is a paid option if you want CPD. The taught and online module content linked to learning outcomes and encompass preoperative assessment, multimorbidity management, frailty, and shared decision-making, to name some of the topics. The second component to the module is the Higher Ward, an option to undertake a work-based learning module at King's College London at level 6 or 7. This comes at an additional cost, but the Higher Ward can count towards an existing programme or can be a standalone module to provide evidence at a degree or master's level. Current plan is to pilot and evaluate the module and content later this year, hoping to roll out early 2021. But whatever you decide, ultimately, you'll need to pay for it somehow. And this will mean a business case. Firstly, ask yourself, what do you think you need? Then park it. Go out and ask your surgical, anaesthetic or pre-admission colleagues what really bugs them and ask them how you can help. Many of our business cases for additional consultants or nurses and junior doctors have been driven by need in a surgical specialty. For example, within urology, it was help supporting transfers of care back to out of hospital. In cardiology, it was ward support with the delirium and discharge management. In gynecology, it was helping reduce lengths of stay in their cancer pathway. You will need to do some scoping. Lots of this is done in your own time, but the benefits will be an increased likelihood that your business case will succeed and you will have a focus for the team member. This will help define the role and set early expectations about what they need to achieve. So, in summary, I think perioperative medicine has the opportunity to lead the way in advanced practice and the extended role of the practitioner. Within the perioperative pathway, this can be done with nurses, allied health professionals, or physician associates. But as we evolve these roles, we must be mindful not to repeat previous mistakes. And this comes with the recognition that not all services will be the same. And there will need to be some scoping to help tailor your service to the needs at that current time. But this will help drive your business case by giving the practitioner role focus and allow you to measure their effectiveness.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.